I really appreciate the opportunity to share this work. This is one of the major projects of my K12, so I will get right into it. I will go through a motivating case that has stuck with me over the years, and I always go back to in thinking about this topic and give you a brief background on UTI in children, just the basics to know for this talk, and then go through my current cross-sectional study, the objective methods, results, and interpretation, and then talk through future directions. And I'll be happy to hopefully have time for Q&A. So this was actually a patient that I saw when I was a medical student. And I was in the pediatric emergency department, and I was seeing this 7-year-old girl who was brought in by her family for worsening abdominal pain and dysuria. And she was a previously healthy child who had about a 5-day history of symptoms that also included decreased appetite and fevers. And she had been seen 2 days previously at another emergency department, and the parents were told that she had a UTI. And she had been prescribed an antibiotic that they had been administering. But they were noticing that despite that, her symptoms had continued to worsen, and so they were worried enough to bring her back to care. And at that point, as a medical student, I was, gung-ho, developing independence, like what can I do, working with my emergency department, supervising physicians, and I got really good advice, like if she has a UTI, like we can just call and find out what the result was, and maybe we need to optimize her therapy better. So I called the hospital where she had been seen, and fortunately, they had done a urine culture and there was no growth. So this result was surprising to me at the time, but it really prompted us to think very carefully and go back to square one and think through, okay, so what else could explain her having these symptoms, including the dysuria? And so we dug a little deeper, did a more expansive diagnostic workup. And this is not her specific imaging, but it's similar in that what we found was an inflammatory mass that was adjacent to her bladder. And ultimately, the diagnosis was not a UTI, but she had acute appendicitis and actually had perforated appendicitis. And because the abdomen in a child is so small, children who have appendicitis can present with urinary symptoms because this is just adjacent to their bladder. And so it was helpful to me to learn so early on that, we can't always predict the diagnosis in terms of thinking about like the most common things, but we have to think expansively about other possibilities. So, in terms of pediatric urinary tract infection diagnostic evaluation, my work is really focused on the entire set of kids who get evaluated. And I'm particularly focused on emergency and urgent care, which has become the predominant setting for diagnosis of UTI in children currently in the United States, and is also a setting where it's really important to be able to recognize other conditions, other acute conditions besides UTI, because children are really coming kind of with undifferentiated acute illness. And there are a lot of different ways that that can go. So what do we need to make a diagnosis of UTI? First, like anyone, a child needs to present with symptoms. However, in children, the symptoms that can be caused by UTI are also common symptoms. So, abdominal pain and fever are some of the most common reasons that children are brought to care overall. And most of those children have relatively self-limiting illnesses, but these can also be symptoms of other major conditions. They're not like especially specific symptoms. And so there's a very broad range of children who may be evaluated. And then the urinalysis is, gives you a same day result as screening test, but it has low specificity. It can be abnormal for many reasons, including UTI, but also other conditions. And then the urine culture, fortunately, in children, there's a relatively low prevalence of asymptomatic bacteriuria. So that's not as much of an issue that we need to be thinking about that can throw us off in terms of our diagnostic evaluation, but it does take time to result. And so that sort of leaves people with a period of uncertainty before the diagnosis is confirmed. And then the urine cultures in children are more prone to contamination at the point of sampling. And this is true even for children who can collect urine by clean catch. It's just a little bit harder for them to do it independently. And so this is, in the context of the way that UTI is diagnosed, and also, I think the context of care with children so often seen in these relatively acute settings like the emergency department, that about half of children who end up starting antibiotics for suspected UTI do not ultimately fulfill these diagnostic criteria. And the main reason for that is not having a positive urine culture. And UTI is among the most common initial diagnoses that are assigned in children and adolescents who ultimately have delayed recognition of other serious conditions like appendicitis or ovarian torsion. And it can also interfere, thinking somebody has one thing when they actually have another. It can kind of change the way that clinicians think about them. It can change the way that caregivers seek care. And it can interfere with recognizing and managing other common causes of lower urinary tract symptoms. And those include voiding dysfunction or bladder and bowel dysfunction in school-age children, as well as sexually transmitted infections in adolescents. And for both of these conditions, UTI is sort of the more likely go-to first diagnosis that people think about and tend to test more and think more about compared to the other alternative diagnoses, which are relatively common. So in my work, I'm really trying to understand how we can better improve our diagnostic processes so that our diagnostic approach is suited to get children the care that they need, including if they have a UTI to get prompt care, if they don't have a UTI to clarify that and provide closure, and then to seek other diagnostic evaluation. So I'm interested really in, the whole group of children who are evaluated. And at this point of the first evaluation in, say, that emergency visit, you have to make a choice. The clinical team has to make a choice, and ideally, this should include some consideration of the family's preferences with good information. Need to make a choice about prescribing an antibiotic empirically for suspected UTI, and that involves a risk trade-off with incomplete information. So for the children who do have UTI, the risk of not starting an antibiotic can include continuation of symptoms, and in the youngest age groups, a higher risk for progression and complications, which can be quite serious. For children who have other conditions who don't have a UTI, antibiotic-related adverse effects are relatively common. There's the individual and community health risk from resistance, as well as the misdiagnostic opportunities like the one I described. And the clinical reasoning versus reality, if you are a fully rational clinical decision maker, you would be expected to integrate risk factors, symptom, and laboratory data based on their relative diagnostic importance. But we know that actual clinicians in the real world have constrained attention and processing and are doing the best they can, but make relatively predictable decision errors and have difficulty integrating information for accurate risk estimates. And there's a precedent for really working to understand actual real world decision making as the basis for developing an effective intervention to address diagnostic misconceptions. So for adult UTI, Barbara Troutner has done a lot of work on the appropriate treatment of asymptomatic bacteriuria in adult hospital settings, and understood early on based on formative work that clinicians have mental models for UTI that include both concordant cues, which are things that are actually good signals about a UTI, and also discordant cues that are not as helpful signals, that are not really strongly associated with UTI. And those are linked to testing and treatment decisions. And if we understand what those discordant cues are, then we can work on those deliberately. And that has led to highly effective interventions. So I'm taking that precedent in my work and the design of this study. So the objective is to assess how current clinical decision-making patterns impact antibiotic overtreatment. So that's the use of antibiotics in children who don't ultimately have a UTI, as well as early UTI treatment initiation in children who do have UTI. And this is looking at these decisions in all children who undergo screening test. The hypothesis is that low levels of pyuria, akin to like the trace leukocyte esterase detection or comparable levels of white blood cells, mainly promote overtreatment and have a minimal association with appropriate early treatment for UTI. The basis of this is that those lowest levels of pyuria have a very small impact on UTI likelihood. And this is a chart of a paper where they did interval likelihood ratios. So I think that the key thing is this last column, the post-test probability. If you go in and you have a negative Luke esterase, your post-test probability was 2% versus 16% at trace versus like much higher if it's up to 3 plus. And then the nitrite is a relatively important and differentiating test. So if you have a positive nitrite, your post-test goes up to 72%. And this is kind of a similar pattern when you look at the white blood cell quantities, that going from the lowest level to the next up level, it doesn't make a huge difference. But we know that that tends to be a signal to clinicians that might make them more likely to prescribe, and that clinicians also tend to overestimate the probability of diseases after having a diagnostic test result. So the methods of the study, it's a cross-sectional study of emergency and urgent care visits in 4 settings. So we're really trying to go very broad to make sure that it's not just findings that are relevant to one place. So we're using data from 2 children's hospital emergency departments, a general emergency department in a public hospital where adults and children are seen in the same setting, and an urgent care clinic in a public hospital. The data source is electronic health records. And we are looking at children who are between 2 months and 17 years of age who have a urinalysis performed with the result available during their visit, discharge home, and we're looking at just 1 visit per patient to avoid sort of the repeat measures issues. And the exclusion criteria, we're really looking for generally healthy children where these guidance statements about interpretation of the testing hold up. So excluding children who have previous urologic surgery, immunodeficiencies, neutropenia, pregnancy, etc. And we also exclude visits with a trauma injury, visit diagnosis, because they commonly have a urinalysis for detection of hematuria. And then we also exclude other non-UTI bacterial infection visit diagnoses because we're really interested in whether the antibiotics were used specifically for a UTI and not another condition. And then we also exclude if they have received another antibiotic preceding the visit. Okay, and then the data that we get is a lot of it EHR-derived structured data, but in that EHR data pool, we also get the free text notes from the clinical encounter, and then go through and manually abstract with a standardized protocol, symptoms, and signs from that initial evaluation note. And we've developed definitions that are based on UMLS concepts so that they're sort of very standardized using sort of a common data definition. And then we also manually validated urine culture data from all sites to ensure that we're getting all of the information to be able to classify those cultures. The analytic framework, so thinking about how do we get at this question of both overtreatment and appropriate treatment. So we have 2 steps. And the main question that we're asking is, was an antibiotic started? And that's sort of the first, what's the outcome in the first model that we fit? We see that as a proxy for clinical decision making, sort of with the assumption that clinicians are more likely to start an antibiotic if they think the child has a UTI. And we are fitting a model in the full population of children evaluated, and the reason we're doing that is to avoid bias through selection. So if we were only to look at overtreatment, classifying overtreatment as contingent on the child not having a UTI. And so by selecting that out and only modeling factors related to overtreatment, we would be introducing a biasing path. So in this way, we are really looking at what are the factors associated with starting an antibiotic at that first visit based on the information we know at the time, which includes things like a child's risk factors, age and sex, their presenting symptoms, and the results of the urinalysis. And then after that model is fit, then we stratify by groups according to their UTI final diagnosis, which I can talk through the criteria that we use for that. And we model the impact of that initial clinical decision making on those two subpopulations, the children who had UTI excluded as a diagnosis and the children who had UTI confirmed. Any questions about this approach before I move on? And please also ask questions if there's something that I can clarify midway, because I want to make sure that everything is clear. The main predictor we're using is the level of pyuria that was detected on the urinalysis. And we have here sort of levels that it's an ordinal categorical variable that's reconciled across different urinalysis methods that are used at these sites. So we're going from comparable to negative, trace, 1 plus, 2 plus, 3 plus Luke esterase. And then we have the UTI classification criteria, which are developed based on UTI guidelines, evidence-based resources, professional guidelines, and really put together prior to looking at the data and then hard-coded based on the structured data and the microbiology results that we get before we do any work on the outcome of interest. So they need to have at least one symptom, to have pyuria by urinalysis, and to have a urine culture with an adequate above threshold quantity of a uropathogen. Okay. So this is the flow diagram of the visit selection from those four sites. So just to walk through, I think the main things are, we pull the visits from patients by age, discharge to home, urinalysis, and then we exclude based on the preceding diagnoses, diagnostic codes. And we've also developed some exclusions to ensure that our data is complete at the point that we go in and fit the model. So we have all of the key information that was available at the encounter, complete and consistent for all of these visits. And then we're sampling evenly across the four sites so that they're equivalently represented in the final study population. And then the one thing that we need to apply based on the actual manual review is whether they had an antibiotic prior to visit, because sometimes that's outside of our systems. And so we excluded visits based on that if we found it in the abstraction process. So we end up with 1,150 visits. And these are all visits that we've classified in detail by their presenting symptoms and have all of their structured data. And I'm just going to walk through the population characteristics, just main things that are notable. So the median age is 6 years. And I think that is notable because I think a lot of people, when they think about evaluating children for urinary tract infection, are thinking about infants and toddlers. And infants and toddlers are certainly the major risk group where most of the urinary tract infections happen. But actually, what I found in this study and also in prior work is that older children are the predominant group that's getting evaluated and diagnosed with urinary tract infection, in particular in emergency department and urgent care. And part of that is just it's so much easier to actually obtain a urine sample in that age group. I think another thing that's notable is that the distribution of presenting symptoms is a little bit different by age group. So for the very young children, just keeping in mind children less than 2 generally can't communicate much about what's going on. So the main symptom that they are evaluated for is fever. And then urinary tract symptoms. So we abstracted like a large list of potential symptoms. And this, for this variable, it's if they had any of those symptoms. So it's a fairly inclusive list. And I think what's notable here is that when you go from, say, being a very young infant or toddler, very few of those children had urinary tract symptoms at presentation. And you go up to the preschool age group, and now it looks like about half of children who had a urine test at their visit were tested probably because they had urinary tract symptoms, and about half did not have those symptoms, and they were probably presenting with things like fever and abdominal pain. It doesn't actually get much more focused after that. So if you think in your life about children in your life, you might expect that people, by the time they reach school age, and certainly by the time they reach adolescence, really like we would expect that they should be able to report some urinary tract symptoms and be able to localize. But it's interesting that we're not seeing that the urine testing necessarily becomes more directed in older age groups. And this is, I think, another thing that may be surprising to people. Like people would assume that we're mainly testing for urinary tract symptoms in the older kids, but we're not actually. And this is just another way of showing that same data. Um, and then the urinalysis results, I think the main thing that's notable is that it's fairly common to have an abnormal urinalysis. And this goes out like across age groups, um, and particularly to have that trace level of leukocyte esterase. Among all people tested, that was about 12% of people tested. And, thankfully, most of the time it is negative. But a fair portion of people tested will have a positive result. And keeping in mind that can be from a lot of other conditions. Okay, and then the urinary tract infection classification. So, of those 1,150 visits, so we apply the criteria for symptoms. So there were 106 who did not meet the symptom criteria. And I think that is notable because that shows us that we don't have the same behavioral target for clinical practice that is observed in adult settings where people are, say, tested when they don't express symptoms. So, for the most part, children who are tested do have some symptoms that qualify under pediatric urinary tract infection definitions. And then among those who had symptoms, um, there were 743 who had no pyuria, so didn't meet the UTI definition because of not having pyuria, and then 301 who had an abnormal urinalysis with pyuria. And among those, 62 had a urine culture result that was consistent with a UTI. 126 had either a negative result or a result that was inconsistent with UTI. And then there were others that we created this indeterminate category to classify results that really couldn't be confidently sorted into either of those. Like there was either like a very large quantity of mixed flora or there was a subthreshold quantity of a pathogen, and that we kept out as indeterminate. But a lot of the indeterminate were actually indeterminate because they didn't have a urine culture. And that is also a departure from evidence-based practice recommendations in pediatrics, which do recommend that a urine culture be used to confirm the diagnosis. And I know that there is some controversy in the field about UTI definitions in children. The guidelines are actually under revision right now. But just to say that discordant cases were relatively uncommon. So there were no visits in which the urine culture result would have met UTI criteria in these children who did not have qualifying symptoms. And there were 4 cases in which there was no pyuria, but the urine culture would have met the UTI criteria. So that's uncommon. And so I don't think very likely to impact the findings of my study with a large sample. And then in terms of who got treatment going by these groups, so among the people who did meet the UTI definition, 56 got an antibiotic and 6 did not get an antibiotic at their initial visit. And in the people who did not meet the UTI definition, and had adequate information to classify, 92 got an antibiotic and 83 did not. And then the treatment in the indeterminate group was also relatively common. So we have 191 events of starting antibiotics, and this entire population is used to fit our initial model. But these UTI subgroups are the ones where we're actually evaluating the impact of the model decision. So I'm going to walk through that to just show you what that looks like. So this is, so now looking at the entire sample of kids who were evaluated, this is a multivariable regression model of factors that were associated with the decision to start an antibiotic at that initial visit. So if it's to the right of the line, then it was associated with being more likely to start an antibiotic. If it's to the left, it was associated with being less likely. So I think the key things are, and I'll show relationships by age. There's a very, very modest relationship to age. And then there's a positive association between having urinary symptoms and starting an antibiotic. And I think that we could say is a concordant clue in that it's aligned with, the actual presentation of a UTI. And then something like diarrhea, which, diarrhea is not a urinary tract infection symptom, that also seems like an aligned cue in that if you have symptoms of another illness, you're less likely to start an antibiotic. And then we find that, at each level of the pyuria detection by urinalysis, there's a pretty strong stepwise increase in likelihood to start an antibiotic at each level. So not too surprising. And then the nitrite is also associated with starting an antibiotic. There's a modest association between like hematuria and starting an antibiotic. And interestingly, also we include site as a covariate to deal with the non-independence of observations within site. And there is some association with the site of care. Okay, so then I think it's always helpful to look at a margins plot when interpreting the output of regression models just to see this in terms of probabilities rather than odds ratios. So what this shows is there is a modest influence of age and a modest interaction between age and urinary tract symptoms on the clinical decision to start an antibiotic. So age in this model is continuous. And there is a linear relationship. So I've centered that at 7 near the mean. And the interpretation of this is that for each year increase in age, you have about a 7% decrease in the odds of antibiotic initiation. So that's what this is showing in terms of probability, that by age, you have a modest decline in likelihood to start antibiotics. And then for urinary tract symptoms, we have an increased odds of antibiotic initiation when those are part of the presenting symptoms. And then we included an interaction term because theoretically, having urinary tract symptoms should be more influential the older you get. The actual relationship here is pretty modest. So if you think about, the 1-year-old, really you should have minimal influence of urinary tract symptoms, but you should start to have a lot more as you get older because they become more detectable. And then the other issue is just the overall age relationship, just knowing what we know about UTI epidemiology, you should be much more likely to start an antibiotic in a 1-year-old or a 2-year-old than an older child. And in particular, in the school age group, the actual occurrence of UTI is very infrequent. There's also a large influence of the urinalysis results. So this is the conversion of those odds ratios from the model onto a margins plot. And it's interesting that it's like fairly stepwise too. So then this here is looking at the stratified analysis. So, taking that model that we've developed in the full population, we then take subgroups. So, we take the UTI negative subgroup and the UTI positive subgroup. And what I've calculated here are population attributable fractions. So, if you think about, say, like a risk factor for disease, say, like smoking, um, this is essentially asking, like, how much does smoking independently impact the observed disease occurrence that we see. And if we took that one risk factor away, how much less would we see? And so it's reflecting adjustment for other factors, and it's reflecting the prevalence of that risk factor within that population or subgroup and the relationship, the strength of the relationship. So what we see here is that going by, say, the trace Luke esterase level, which is our sort of main predictor of interest, main hypothesized issue, when that is present, the way that clinicians respond to it contributes much more to overtreatment. So that accounts for about 17% of the antibiotic overtreatment and about 2% of the appropriate treatment initiation in children with UTI. And as you go up, the contribution of the intermediate levels, 1 plus and 2 plus, actually is a little bit more balanced. So it's not as differentiating the way that clinicians are using that information currently in clinical practice. Whereas if you look at, say, at the 3 plus level, starting at the way that people are treating that is generally differentiating towards appropriate antibiotic initiation in people who do have UTI. And the same for the nitrite, that's generally differentiating and leading people to appropriately treat much more than to overtreat. And part of the reason it's so small is just that nitrite detection is relatively uncommon. Um, and, that sort of reflects the impact on the overall subgroup. I'm going to stop and see if there are any questions about this because I think making the connection between this and the prior is pretty important, and I want to make sure I address any questions.
I'm looking in the chat also in case anyone wants to put in the chat. I guess I have one really quick one as you're going. Were you able to control for any factors, such as like household income or sort of area code? I was thinking about your sites, and how different they were, at least four compared to one, three, and I was just wondering if if that was a driving factor to imagining if you were in a lower household income, area, or that hospital was, maybe then children would be brought in with already worsening symptoms or something like that. I wonder if there are a bigger portion of those that already had present symptoms versus those that didn't, or something like that.
Yeah, that's a great question. No, and I think that's a just a limitation to be aware of is that we're not accounting for social determinants, and we also don't account for things like clinician level determinants, so like who they saw in the setting. Um, just addressing sort of the like relative severity of illness, our study focused exclusively on children who were discharged home at the end of the visit. So that would have been, we presume, a population of children that was clinically stable and felt to be safe to go home. But I do think it's a good question and something that, if you think about it, could be a driver of antibiotic prescribing. If you see the patient is potentially more vulnerable, like, you know, if you saw them on a Friday night, you can imagine you might be a little bit more likely to prescribe on a Friday night than say like a Wednesday morning. And I think totally fair that those could be factors that are influential and some of those appropriately. So um, here, I think our findings are really mainly focused on clinical cues. And I can show if anybody is interested in seeing like some regression model diagnostics. It's actually like a pretty well-fitting model to the data. So that most of the variation in data is well accounted for in the model. Anything else? Okay. So really like using this approach, calculating the attributable fraction in the distinct subgroups gives us an idea of how clinicians are using the information that they have on hand to make treatment decisions and how the current approaches that they're taking are in some ways aligned with the likelihood of UTI and should be encouraged, uh, versus in some ways misaligned with actual the strength of the signal. And those ones where they're most misaligned, like the trace level of leukosterase, are factors that we can intervene on with a high likelihood of being able to reduce overtreatment, but also a low likelihood of negatively impacting children who do have UTI, and that we can feel more confident and safe in intervening on those factors, in that they're selective. So those are exactly the types of targets that I'm interested in finding in this study. Um, so the interpretation, this trace level, low level of pyuria explains about 17% of excess antibiotic initiation, only 2% of appropriate early treatment initiation. So that supports the hypothesis that this can be a good selective target for intervention. Um, I think, key things to the interpretation are that this reflects clinical decision making as observed in practice, and this could potentially change if there were other interventions already in effect or in very different care settings from what I've described. And then there are also some assumptions that are needed for the regression model as the basis for causal inference in the way that I have used it. So having no unmeasured confounders, having a correct model specification, adequate exposure, covariate overlap, and adequate sample size and number of events. And so I think in general, our approach is fairly robust for these issues, but just to be aware of those issues in terms of the takeaways from this analysis. Um, Another, I think, key observation is that there are other factors that are underweighted in clinical decision making relative to their actual importance as UTI risk factors. And the main one is age here. And so if we are thinking about interventions that, we could actually help people cue in better to age and to recognize that the younger children ought to be treated a little bit more cautiously compared to older children. Um, and this could be explained if testing were much more selective in older age groups, but as I showed earlier, our findings really don't support this. So the testing for less specific symptoms, less localizing symptoms was also common in older age groups. And in a previous study, we actually found that on average, older children and adolescents are a lot more likely than younger children to undergo urine testing in ED settings. Um, One possible intervention to highlight is there is a urinalysis interpretation algorithm that was a part of an intervention used in another setting. And that intervention was successful in reducing a portion of the overtreatment. And it was also found to be relatively safe in terms of the short-term deferral of treatment initiation in a small number of patients. And this algorithm, this one that I'm showing, is from the Hospital for Sick Children in Toronto. And then there's also something similar in the Children's Hospital of Philadelphia UTI algorithm, where they have different treatment recommendations by age, and they build in the nitrite as an important cue to lead you to treat more, which is, I think appropriate and well aligned. But then they give you a little bit higher threshold of pyuria to start treatment. So if I can actually use my data set and my model that I've developed um, to evaluate what would be the potential impact of an algorithm like this if we were to implement it in these four sites. So setting up a counterfactual scenario, making predictions based on that, and then modeling the impact and particularly modeling the impact in the distinct subgroups of children with UTI and children without a UTI. And for this one, I found it actually has a fairly favorable and a relatively selective impact in that that would decrease treatment initiation by about 25% in the children without UTI and by about 5% in the children with UTI. And that would be predominantly in the older age group that is at lower risk for complications and progression. So this seems like a favorable intervention option. And then another one that I looked into was the possibility of just drawing more attention to age and to urinary tract symptoms. What we found were like kind of modest relationships in current practice. But say if we ask people to really defer treatment, if it's a child older than 6 who does not have any urinary tract symptoms at all, and then modeling the impact of that, that would also be relatively selective in that it would reduce the overtreatment by about 8% and reduce appropriate treatment initiation by about 2%. Um, so these are estimates. Of course, in a real world system, it's hard to change just one thing at a time. And all interventions in real world settings really should be monitored in progress for both intended and unintended consequences to see to all the key subgroups that are affected. Um, some of the strengths of my study, just to highlight, are having a large multi-site sample that enhances the generalizability to other urgent care and ED settings, and having a comprehensive and standardized process for abstracting symptoms. And then we have a pre-specified hypothesis-driven analysis that minimizes the bias in our findings. The limitations, as Alex mentioned, definitely we're focused on patient level clinical factors. So we might miss social determinants, clinician and facility level factors that are important. Um, Data also are originally collected for clinical care. So there's a possibility that there could be inconsistency in the original capture of symptom and sign constructs. However, most of the data elements used, and particularly the primary predictor, were structured data. And just also to mention, we don't have standardized research definitions for pediatric UTI. So what we used is a composite of classification criteria based on prior studies, guidelines, and expert resources that, I think the best we can do is report our approach in detail to enable reproducibility. Okay, future directions. I am also interested in looking at antibiotic discontinuation in children who don't have UTI, and we have the data to be able to do that. And I'm looking forward to doing a mixed methods analysis to identify like what are some of the issues around the assessment of those results and the putting together both structured and qualitative methods. And then I also have a study in progress that is conducting qualitative interviews with both clinicians and caregivers of children to understand perspectives on the decision making that goes into this process. And so, in a way, that somewhat addresses some of the social determinants that Alex mentioned. And the ultimate goal is to develop an intervention that improves application of evidence in clinical practice. I also think there are a lot of gaps I've discovered in the process that we really need to strengthen the primary evidence base for UTI diagnostic epidemiology in older children in particular. So the clinical prediction of UTI in those older age groups, and then more comparative effectiveness studies of UTI management strategies in the older children in particular, because a lot of pediatric research on UTI has focused exclusively on the infant and toddler age group. These are just to highlight and acknowledge my collaborators and funding sources. I'm really grateful for the opportunity to do this work supported by the UCSF Kaiser UroEpi K12 and my fantastic team of mentors, advisors, and collaborators.